Yeah, I'm gonna be presenting our experience in the University of Texas, Houston. There is a lot of effort for many people here. We have the cardiologists, pulmonologists, critical care, trauma surgeons, cardiothoracic surgeons, hemotherapists, etc. So I think they choose me because my accent. But this is our experience. So VV ECMO utilization in hypoxic trauma patients. And so despite the establishment of high level of care in trauma expertise, injury remains as the third cause of death, the general death in the United States. And not only that, is the first leading cause of death from ages from 1 year old to 44 years old. So after conventional management of traumatic respiratory failure, limited options are available. ECMO can support these patients where there is refractory hypoxemic respiratory failure. But the problem is ECMO in trauma patient experience is limited and not without any controversy or limitations. Some of the ECMO limitation is the availability of the ECMO in the trauma centers, the lack of knowledge for the implementation of this device, and of course the potential hemorrhagic and neurologic complications in these very sick patients. So we are blessed to be located in the medical center, so the University of Texas and the Memorial Hermann affiliation. So we have an advanced cardiopulmonary therapy and transplantation department in the same hospital where there is a trauma 1 level for sick patients. So we have provide ECMO support for 6 years in that hospital. And we did a retrospective study on our single institution. Even when our group started in 2012, we started getting consult for ECMO support in trauma patients from 2014, 2018. We did this data collection retrospectively with the demographic and clinical data. We took a look at the age, gender, BMI, trauma mechanism, injury severity score, PF radio, REF score, and we're lucky that the majority of these patients has a CT head and a neuro status before the ECMO was started, when this patient arrived to the hospital. And then we calculate the time between the admission and the ECMO initiation, ECMO duration, and after the ECMO was removed, this patient, how long they stayed in the hospital. We saw about the survival and also the neurologic adverse event. Very important, we also analyzed the anticoagulation strategy that was used, the initiation, maintenance, and the hemorrhagic injuries, if there was any progression, or if there was any ischemic neurologic injury, if there was any conversion to hemorrhagic. The outcome was ECMO-related complication, basically the neuro adverse event with an intracranial hemorrhage for progression, or if there was any ischemic, if there was any conversion, and also the survival. We follow, just to let you know, we follow the guidelines that the American College of Chest Physicians has for the management of ARDS. And we follow this in the ventilatory management and the non-ventilatory management. We use what we call the REP score, which is designed to assist the prediction of survival for patients that undergoing ECMO support for respiratory failure. And our institution, the trauma team, used the injury severity score, which is a score that has 6 regions of the body, and there is an abbreviated injury scale for each of this region, and then you take the sum of the 3 highest one, and that will give you a score, and that score will grade these injuries in minor, moderate, serious, severe, critical, or maximum, and this is correlated with mortality. So the result, we have 15 patients that were placed on venous ECMO due to predominant hypoxemic hypercapnic respiratory failure. The mean age was 30 years, the median was 24, and this patient has minimal comorbidity. The gender was 94%, and the mechanism of trauma was 100% was blunt trauma, with the motor vehicle collision being 60%, motorcycle in 20%, and the rest were auto versus pedestrian and fall. We calculate the average of the rest score for all comers and was minus 1.2. The PF rate of the average was 49 and with a 53 of median, but the highest PF radio that we have was 76. The injury severity score average was 34, which is severe, and the median was 34. So 13 out of 15 patients was weaned from VV ECMO successfully, and 87% of these patients survived to discharge. So the mortality was 13%. This table just shows about the demographics. You can see very young population with minimal comorbidities. The interval between the admission and the initiation of ECMO was 3 days. The duration of the ECMO was 2 weeks, and the termination to discharge was 30 days. So these patients stayed in the hospital around 48.9 days. Here we are showing the RESP curve that we have in this patient on red, and the blue is the injury severity score. And when we did the analysis about the RESP score, there was a big difference between survivors and non-survivors. It was 0 against -7, which tells you about the predictor for this tool. But also, the injury severity score actually was higher on the survivors versus non-survivors, but this was not statistically different. More important, the neuro, when we were analyzing the data, I got very surprised. We have 4 patients that has already intracranial issues. The majority were bleeding, like small subdurals or a small subarachnoid, even cortical lesions. There was 1 patient that has a ischemic event before putting on ECMO. So 4 of those were 26% of this patient has already an intracranial issue before the ECMO initiation. And most of them never progressed. You can see we start the anticoagulation the same date on all of these patients, and we get to the level of a good PTT in a good time. There was 1 patient that has no any other injury, and this patient has progressed with an intracranial bleed after. Our recommendation is ECMO is a good tool for these patients. It have to be a very selected patients, but we think this is a very productive population, very young population that we can help with a multidisciplinary approach.